Great. Without further ado, Dr. Adishesh, if you'd like to share your screen, you can, or we can for you if you'd prefer not, and as I introduce you. So Dr. Anil Adishesh graduated in medicine at the University of Liverpool in the UK. He trained in general medicine and then family medicine and is specialty trained in occupational medicine. He obtained an MSc in occupational health sciences and undertook doctoral studies on the respiratory health effects of occupational organic dust exposures at the University of Manchester. He worked as a Deputy Chief Medical Officer at the UK Health and Safety Executive National Laboratory. Moved to Canada in 2013, being appointed the inaugural J.D. Irving Limited Research Chair in Occupational Medicine at Dalhousie University, and in 2019, Division Director of Occupational Medicine in the Department of Medicine at the University of Toronto, before transferring back to New Brunswick in 2022 to work with Canadian Health Solutions and Dalhousie University. He chaired the World Health Organization Global Working Group on Occupational Health for the revision of the International Classification of Disease, the ICD-11 codes, for those of us who know those. He co-edited the International Labour Organization's 2022 publication Diagnostic and Exposure Criteria for Occupational Disease, Guidance Notes for Diagnosis and Prevention of the disease in the ILO list of occupational disease revised in 2010. He is the immediate past president of the Occupational Medicine Specialists of Canada. Welcome, Dr. Adishesh. We are not hearing you, but we see your slides beautifully.
Yeah, you're hearing me now, though.
I am. Thank you.
Okay, great. Right. So, yes, I'm going to be talking to you about this project called ECHO OEM and how we're providing the tools for primary care to get work done. And so it goes to some of the implementation, I think, of what Lynn was recommending earlier. So let me see. So that's a disclosure slide if it's needed. Not sure if it is. So a few grants and things. Also, as a startup, I have called Occupy. That's Occupational Health Informatics. You might ask me what's that? Well, I'm coining the phrase, and there's an editorial I've written on that in occupational medicine. But largely, it's to do with occupation coding, also something Lynn was talking about. And we have an international partnership on that I was at a meeting of earlier today. So all this technology is on its way. Okay, and this is a disclosure around the ECHO program itself. So the ECHO program OEM was funded by WSIB with an educational grant. Okay, so this is what we're going to talk about is about ECHO itself, tell you a bit about the ECHO program, and then specifically about the ECHO Occupational Environmental Medicine and how we're addressing the knowledge gap in primary care. Some important features of taking an occupational history, but specifically with reference to the occupational history recording tool, which is something that we've developed as a result of running the ECHO OEM program. So why ECHO and what is ECHO? So it stands for Extensions of Community Health Outreach, hence ECHO, and it was started in New Mexico by Dr. Sanjay Arora, who's here, and Dr. Sanjay Arora is a hepatologist by background, and he practices at the University of New Mexico in a specialist center, tertiary center, but for his hepatitis C patients in particular, he was finding there were worse outcomes for them when they were in rural, underserved communities. And he wanted to get education to those practitioners in the communities because he couldn't visit them all. So he started using a telemedicine model, giving them some didactic talks and helping them with cases that they had difficulty with, and developed that into a model of education and management by helping the practitioners manage their own cases. So the way ECHO sessions are structured is in this way, that there's a didactic presentation by a subject matter expert. So it's a way of transferring knowledge and helping build skills and confidence in the people that are attending, the participants attending the echo. And then the participants themselves, that's where the cases come from. So a patient case is presented by a primary care participant, and that helps them manage, maybe difficult cases or reflect on cases that maybe they feel haven't gone so well, and complex cases. And what happens is that first of all, the primary care participants, after the case has been presented, they ask any clarifying questions. Then the expert group, or hub as it's often called, ask any clarifying questions they've got. Then the participant group, they give any advice or recommendations they may have, and then the expert group do similar. And it's structured in that way in particular, with the expert group providing their clarifying questions and advice after the participants, so that it doesn't inhibit any discussion, because we don't want the expert groups to present a recommendation, then everybody else think, well, I'm not sure that my recommendations are going to be as valuable, so I won't say anything. We don't want that. We want interaction and we want discussions, and the main thing is that we all learn from each other. And this slide shows that. So to facilitate the ECHO program, you have a specialist or expert hub, so subject matter experts, and these are all delivered by a video conference network to the primary care participants who are, in their own clinics or at home or wherever. And there's this discussion between the experts and the primary care team. But also, as I said, the primary care team participants, they provide their own clarifying questions, ask their questions, and also provide recommendations. And so their other colleagues are listening, and so everybody's learning from each other, because they've all got tips and hints. They're out in the community. The specialists, they don't necessarily know that. Or you learn of different working experiences if we're talking about a work situation. But the main theme is that we're all teaching and we're all learning from each other, and it's based on having interactive discussion in order to create a community of learning and build capacity. That's what it's about, is making sure that the specialty care that is specialist, and hence it's in a centre, can get out to underserved communities by this knowledge translation. And ECHO itself is a global program. So this is the wider ECHO, and there are more than 330 hubs, as you can see there, around the world, 70 diseases and conditions in 37 countries. Now, within Ontario, the ECHO program started with the Ministry of Health funding ECHO in 2014, a 2-year demonstration project around opioids. And this led to chronic pain and opioid stewardship ECHO at University Hospital Network. And that's led by Dr. Andrea Furlan. And Andrea is the principal investigator with me for the ECHO OEM. So it's thanks to Andrea that this was set up. But more than just the chronic pain ECHO, all of these other ECHOs are also set up, and the genesis of those has also been due to Andrea's enthusiasm and initiative. And you can see the many programs. There's over 30 now, so they're not actually all shown on this slide, but you can see an occupational environmental medicine ECHO. And this is the first occupational environmental medicine ECHO worldwide. So out of those 300 odd hubs, etc. worldwide, this is the first one for occupational environmental medicine. And we said about getting specialist knowledge out into the community, and this graph is, you can see it's taken from the CMA website, Canadian Medical Association website, and this is showing specialist physicians, Royal College specialist physicians in occupational medicine, and in Canada. And you can see that the numbers, the overall numbers, they're around 50 odd about 52, I think, in active practice overall, and so there's not a lot to go around. And I'm speaking to you today from New Brunswick, and as far as I'm aware, I'm the only Royal College accredited specialist east of Montreal. So people are thinly spread, but they're kind of clustered a bit as well. So there's a bit of a cluster of occupational physicians in Ontario. There's a bit of a cluster in also in BC, and also a bit in Alberta, particularly around Edmonton there. So there's, as well as there being a low number, they're not evenly spread across the country. So that means that access to a Royal College specialist isn't going to be easy for everybody. And so with WSIB funding, we set up this ECHO in occupational environmental medicine, and we started off with a scoping review with a question about what are physicians' needs in returning ill or injured workers to work, with the goal of identifying primary care physicians' learning needs and the gaps or inconsistencies, key areas to guide future research. And we used that to develop our curriculum for the ECHO program that we were setting up. And that scoping review, if you want to read it in some more detail, that's published in the journal Occupational Rehabilitation back in May 2022. That was published. What we found was there were 4 categories of learning needs, and those are around administrative tasks, things like record keeping. By that we mean when a physician's keeping a record, have they recorded things like a job, for instance? What's the person's job title? And if there's a question of any work relatedness in the condition, is that in the medical record? And if somebody was injured, mechanisms of injury, is there a good description of that? And then all of that helps with things like communication and collaboration in the future, or coordination of services, because if this information is available, then it's there to share. There's issues around time management for physicians as well. So Lynn was saying, that physicians have little time, so they don't want extra burden of time. So how can we facilitate this for people as well, whilst providing knowledge for them? Then there's attitudes and beliefs. So sometimes the physicians don't have the self-confidence because maybe they haven't got the training, so they don't feel it's an area they know much about. They may not understand their role. They see themselves as a patient advocate, and they are, but sometimes they misunderstand the role of effective advocacy. It doesn't mean doing what somebody's asking you, but doing what's in their best interest. And that isn't necessarily the same as what somebody may ask you to do. There may be some biases as well. That's an issue that's come across, particularly in some of the American research, where it's been shown that some of the Black patients and patients from different socioeconomic classes get treated differently, different advice given to them, different prescriptions even given to them, and sometimes a culture of blaming the patient. Recognition, specific knowledge that there are, for instance, special populations, more vulnerable groups like adolescents and pregnant workers as well. And awareness of what services are around and tools. And so I've highlighted tools there because we're going to be talking about one of the tools in a moment. So ECHO OEM started off as a pilot, and we ran it cycle 1 from in 2021, September to December. It was run on Fridays, 1 to 2:30, and I've just come from one of the ECHO sessions today to this meeting. Cycle 2 was run in 2022 there, total 1 on Fridays. We tried a slightly different time there. And these are the people with the blue backgrounds are mostly the hub members, and you may recognize some of them. This is Dr. Furlan, Dr. Andrea Furlan, who's a physiatrist and a specialist in pain medicine. And this person should look familiar to you. I'm twice on your screen at the moment. This is Dr. Baden Nurozakia, who's assistant professor in occupational therapy. And you may know Dr. Aaron Thompson, the WSIB CMO. And it's been great having Aaron on the group because it's meant that people attending this echo have had direct access to the CMO of WSIB, and he interacts very effectively with people. And Dr. Victoria Arundale, who's an occupational hygienist, Dr. Nadia Aleem, who's an occupational psychiatrist, and this person was Drew, who was the Ontario Occupational Health Nurses Association chair, and Lena, who is the current chair, is now on the committee with us. Dr. Vincent Spilchuk, who works for PHO and also at St. Michael's. And then these are the support staff from the IWH. So who's been attending ECHO in our first 2 cycles? It was mostly family physicians, and that increased in the second cycle. We've had chiropractors, registered nurses, some specialist MDs, nurse practitioners, psychologists, physiotherapists, students, some others, occupational therapists, kinesiologists. And there's obviously a need and a want for this because, you know, for instance, the ECHO that I was on earlier today, we had participants from Pakistan, Peru, and the UK. So, you know, even people from other countries and Brunei as well, we had somebody. So, yeah, people even from other countries are sort of aware of it and attending. And then I mentioned that we have the didactics, but we also have a case presented by our participants. And what this chart is showing is the cases over those 12 sessions that were presented, or the 2 cycles of 12 sessions there. So PTSD type cases arising from work, where again these are that the participants are bringing because they may have questions around or they've had difficulties in managing these cases. Musculoskeletal injury, chemical exposures, some concussion cases, mental health conditions, caregiver strain, which is maybe somebody who's got caregiving responsibilities at home, and that's impacting on their ability to do work, perhaps. Where there was non-adherence to treatment in one case there, musculoskeletal injury and pain, particularly more pain management one. Another chemical exposure where it was some aerosolized sealant, occupational dust exposures, and questions around PPE, low vision, and pregnancy as well. So a range of cases there. So this is the occupational history recording tool. I'm not expecting you to be able to read that, but it's a 1-page tool, so it's 2-sided. It's electronic, so people can print it off. And you know, why should people use it? Well, because it should help with time management, and I'll explain how it should do that. And the record keeping we were talking about. So much of what should be needed for records, if this is completed, it should be available. And then that can help with communication, because if you've got the information, you can communicate it. And that also facilitates collaboration with other agencies or any other services or support that may be helpful to a patient client, as well as meaning that the information can be used to inform clinical assessment. Also, there's the potential for gathering some environmental exposure information. And when it comes to disclosing information as well, then the information's available at hand for disclosure. And prognosis and special populations. So again, we ask, there's some questions there asking about adolescents, pregnant workers. So we'll look at the questions on the occupational history recording tool now. So the first thing to note is that it's addressed to the patient. So it's about your work and your health and well-being. So it's your answers to these questions will help your healthcare provider understand the possible effect of your current or previous work on your health and well-being, and of your health on your ability to do your work. So it's both ways around. It's not only about you know, those situations where work may have caused a condition, but also about somebody's ability to do their work where they've got a condition that's not necessarily work related. And the reason it's addressed to the patient is because our suggestion to healthcare providers is that they print these off and give them to patients to complete, maybe while they're in the waiting room, or even if they want to, they could ask them to complete it before they come to an appointment and bring it with them. But the idea is that maybe they complete it in the waiting room, come into the consultation with it, and then it's there for the clinician to use the information. And they haven't had to take the time of gathering the information. So where some of these questions come from, so you may have heard of the CanPath study, which is a large Canadian study. The Ontario Health Study is a constituent part of CanPath, but it's got about 6 regional parts now. Where I am, the Atlantic Path covers the Atlantic provinces, but it has around about 350,000 participants, and they have a questionnaire that people complete periodically. So this question's taken from there, and this is about current employment status. This is another CanPath one, which is about if they're not currently employed, when was their last work, and then how long have they been at the current job. And for the current job or last job worked, give the full job title and be specific. And this is the ILO recommended way of asking it that comes from the ISCO 08 occupational classification. So that's the way it suggests asking occupation. Then some further questions. And this one is the ILO recommended way of asking about industry. So when you've asked about the job, then what are the tasks or duties in the job? And then another CanPath or Canadian Health Measures survey question around shift work. So to get an idea if somebody's doing shift work, and you can see that, you know, that could be useful for a clinician to know, you know, if their patient's doing regular night shift work or some other form of irregular shift work, depending on their medical condition, that could have relevance as well. This questionnaire here, question here about hazardous exposures it's modified from, it's a kind of mnemonic that comes from this paper by Schumann and others called WAX, which is something like what do you do, how do you do it, are you concerned about any exposures, and so this is the A in the WAX, and then what concerns you and why. And then there's a question here. There's no great source for me to or us to find a question there on a validated question on personal protective equipment, but we thought it worth asking if people use that at work, because if you're using that, you should have a reason why you're using it. And also asking people, do they have a medical condition caused or made worse by work? So do they believe they have, and if so, what is it? What do they think caused it? And that's based on a question from the UK self-reported work illness study, which is it's a supplementary question to the labour force survey that's conducted in the UK. And this is the C of the WAX, which is co-workers. Do your co-workers have any medical conditions caused or made worse by work? And then more or less the last question on it is the current workability, how well you can do your job compared to your highest workability ever. So assuming your workability at its best is a value of 10, how many points would you give to your current workability, where 0 is can't work at all and 10 is workability at its best? And this comes from the Finnish Workability Index. It's a tool I quite like. It's mostly used in the Scandinavian countries. It's being used in Germany and some of the other European countries also, but and I'm using it in my current work as well. I do quite like the questionnaire. It's got 7 main questions on it, but this is the most predictive one, and it can be used as a sole question, and we've used that one there. And then lastly, we ask about this S of WAX, which is, are you satisfied with your current job? and then there's a bit more space for a few more jobs for previous duties, and a little bit at the bottom for office use as to when it was completed and whether it was self-completed or whether somebody else helped the person complete it. So are the questions useful? So we tested it out in our initial pilot that we did of the Echo OEM, and we asked some of our participants that had used it, how did they find it? So these are the sorts of answers we got. That one of the family physicians said, help me get a better understanding of my patient's duties at work, how it affects their functional and mental health, and again, an idea of how work affects health. Another family physician, occupational health and wellness nurse there, saying a clear objective picture of roles and tasks. And another nurse there who clearly was quite enthusiastic about the tool. And so in this round of Echo, we're further disseminating the tool to evaluate it and get more detailed feedback as to whether there's any modifications that we may need to make or changes to it. If you think the Echo might be of interest to you, or you know any other primary care practitioners who you think it'd be valuable to, there's the website there where you can go to, and you can see here's today's session that we've just done, which was recognizing occupational and environmental hazards, and that talk was given by Dr. Victoria Arundale, occupational hygienist that you know. So even one of the primary care practitioners was asking her some questions about how she got into occupational hygiene, and you know, there's obviously some interest in that because they hadn't heard about occupational hygienists before, because they're also a rare breed. And then I'll just finish off for those of you that are in Ontario, Toronto, or if you might visit there. If you go to the Royal Ontario Museum, you can see this sarcophagus there. And this is on the sarcophagus. So it tells you, as it says on the label there, that this is the mummy of Narkt. And it says that this cartouche here, that Narkt was a young weaver from a small temple on the west bank of the Nile. His mummy was autopsied in 1974 in Toronto. And when he died 3,000 years ago, someone from his family loved him enough to ensure he was buried in a good quality coffin where his name and occupation were recorded for all eternity. So that's how important jobs are to people. And there you can see he's a weaver there. And if we were coding him in the Canadian National Occupational Classification, that's the code he would get. And that's thank you very much from me. So I'm open to any questions that you may have.
Thank you so much. Is how far we've come and how far we have to go. Thank you for making that link for us. Sorry, I'm really struggling with a little bit of November cold here. And a shout out to Sarah from the Institute for Work and Health. We had for getting this idea going, and poor Dr. Furlan, who I was harassing. And then thank you again to Dr. Anil. But any questions, more than welcome to put up your hand. I really love, I have to say, while we wait for questions or put them in the chat, the occupational exposure history tool. We also were working on one, and I think we've talked about, we want to follow up on collaborations. And actually in the study that Lynn and Janet did, that was one of our big recommendations, was that workers would have like an app, but we called it sort of a passport, which was, you know, something like your tool, but imagining that people could have that on their mobile phone, you know, rather than filling out a form that they bring to their physician, and even loading SDSs in it, and having, you know, something really amazing for people to almost have a CV, but we called it a passport because it would be so much more information. And so excellent. And I did put the link into the physician clinician toolkit. I know it's been a long time, Dr. Adishesh, but a lot of these tools would be great linked in there with our CCOHS website as well, and the Echo OEM information. So we'll have to see if we can get that in there as well. I'm not.
Yeah, I was slightly remiss not to mention when we're on this web page, if you go to the resources here, you can find the occupational history recording tool. And so I'd encourage people to download it and use it. Our preference is that you go to this link to get it, because to do that, then you need to put in an email address. And the point in doing that is because we want to evaluate the tool. If you're downloading it, then we'd like to contact you to get some feedback as to how you found it. And that's one way we get the feedback. So it's available for free download there. And yeah, we'd like to hear from you as to how you're finding it. Okay.
Excellent. And Sarah's put that in the chat for you, and as well as a couple of really good other links. And yes, we do want everyone using, so please do use it. We used to call them, we had worked on Dear Physician, Dear Doctor letters, and this is a even better version of that people can take to their physician. So this is, yes, please do use it and take it. I know it's a tool for the physician, but the worker fills it out. So it's kind of, merging those worlds and having them talk to one another would be great. I'm not seeing any other questions pop up or hands as we go, as I'm chatting, but if there are, please do unmute yourself, raise your hand, or write your question in the chat. Have I missed anything, Jen or anyone? You just did such a great job that we have no questions on this Friday afternoon.
I don't see any either, Kimberly.
Okay. So yes, thank you all for joining us. I did just want a shout out to occupational illness among military as we go into and thank people for their service into this Remembrance Day weekend, and thinking about their chronic illness as we work on some files where there's Agent Orange exposure, both to military and hydro workers, and throw if you could throw the survey, Jen, in the chat, and please do join us next week where we're linking exposure to disease with some presentations around dermal exposures. And then the week following, we're going to dig into airborne hazard management programs with the new mining regs and how people can implement those and tricks for the compliance to the new mining regs. So again, thank you so much, Dr. Adishesh, and for sharing your knowledge and keeping your flag risen to expand knowledge into primary care physicians. I really, the passion is evident, and we love to continue our partnerships on all of this. And again, thanks, Sarah.
Yeah, we'd love to see it go global. So
yeah, let's do it. Yeah, that'd be good. Yeah. All right. Well, then without further ado, I will give you back a few minutes in your day, folks, on a Friday afternoon. So take good care. Stay safe.
Bye now.
Thank you. Bye.